Let's imagine it's a regular day in the office. You get in there, you're ready to see your first patient, and it's a 52-year-old man with absolutely no complaints that comes in for his annual physical exam. You get in there, the patient has no complaints, you do a physical exam, it's completely normal. You go ahead and start reviewing the lab work that you've pre-ordered for this visit, and everything is completely normal with the exception of the CBC. In the CBC, you notice that the patient has a white blood cell count of 14,000 with predominance of neutrophils. The rest of the differential, completely normal. Platelets, completely normal. Do you send the patient to hematology? Do you send the patient to the hospital? Do you want a bone marrow biopsy? Do you repeat the CBC in 2 weeks? Do you tell the patient go home and not to worry about it? Today, we're going to tackle these issues here. By the end of the video, you will be able to recognize normal patterns that you don't need to worry about or you can manage. And also, hopefully, you will be able to recognize early signs of serious medical illnesses. For that, I am going to bring in my friend and colleague, Dr. Eloy Roman, a board-certified hematologist oncologist with vast experience in the field. I'll ask him several questions. How to approach a CBC? What does he think a primary care physician should know about this issue before calling hematology? What does he wish we do not to trigger unnecessary consults and unnecessary testing, by the way? At the end of the video, the last part will be a practical approach to board exam questions. We will review together board-style ABIM questions on the subject. My hope is that that will serve you to embed this knowledge in your mind. And if you're in the process of certification or recertification for your boards, this will be of a tremendous help. The CBC is not just a collection of numbers. The CBC is a snapshot of bone marrow function, of immune status, of systemic inflammation, and maybe of also nutritional status. And maybe also it's a snapshot of an early upcoming serious malignancy. The objective of the video, again, is to make you understand these concepts, recognize it, not to panic, and act with confidence. Let's get to Dr. Roman. Hello, I'm a practicing physician. I am in the clinic every day. I see patients every day, and I look at CBCs and labs every day. That's part of my daily work. When I look at a CBC, what am I looking at? How should I approach that?
I think excellent question. And it's quite simple, but at the same time, it's very difficult. And I'll tell you what I mean. You have to look at the CBC in its entirety. For example, when you examine a patient, you're looking at the whole patient. Well, for me, I look at the whole CBC. I look at the total white blood cell count. I look at the hemoglobin. I look at the platelet count. And I look at the differential. Remember, your neutrophils, lymphocytes, monocytes, eosinophils, and basophils. All of those together, when you add those up, that gives you your total white blood cell count. And as an example, I've seen patients that have a totally normal white blood cell count, but an abnormal differential. And that is not good. That's completely abnormal. That person can have something as serious as an acute leukemia, for example. So that's one of the first things you have to look at. Look at the entire CBC. The next thing that you need to do is to determine what is abnormal. Is it only your white blood cell count that's either elevated or low? Does the person have an abnormality with their hemoglobin, meaning are they anemic or do they have polycythemia? And what is the platelet count? Do they have a thrombocytosis or a thrombocytopenia? And if you have a person that only has one cell line involved, usually that's less significant than, for example, if they have a bicytopenia. And of course, if they have a complete pancytopenia, that's even more significant. So again, the teaching point is look at the entire CBC.
All right. So I looked at the entire CBC. Now I have this patient with me, and I have somebody that has a white blood cell count of 14,000 and the is with predominance of neutrophils. The patient is absolutely normal. He doesn't have any problems, no symptoms. Physical exam is completely normal. Should I be worried? What do you think? What's your take on that particular case?
All right, excellent question. So you're telling me it's a completely asymptomatic person that walks in and the only thing that they have is an abnormal CBC, specifically a leukocytosis. And when you look down at the differential, it's all neutrophils. Okay, I see this all the time. As a thought process, you should automatically start to think, okay, what's going on here? Does this person have an abnormality in their bone marrow? Okay, like for example, a myeloproliferative disorder or something of that sort. Or do they have something reactive that's revving up their bone marrow that could be transient or could be chronic, for example? Or are they having demargination? So let's get the demargination out of the way. When a person takes steroids, it's no secret. We all know that can elevate your white blood cell count, and that's mainly due to demargination. So our blood vessels are lined with neutrophils. When you take a steroid, that causes those white blood cells to break off of the arteries and veins, and that will transiently elevate your neutrophil count. And it's something that you ask the patient, are you on steroids? Yes, I am. Chances are that's what's going on. Now, the next thing you want to know, okay, if it's not demargination, is it, like I said, a bone marrow issue or is it something reactive? Well, reactive is by far the most common. Is this person having an infection? Do they have a viral illness? You know, can they have HIV, for example? Can they have a flu, a common cold? Do they have a C. diff, a bacterial infection? Very commonly can elevate your white blood cells, especially your neutrophils. I've seen C. diff causing elevated white counts or neutrophils of, 20,000, 30,000. Very common. So if this person is having diarrhea, of course, that's where you're thinking. What medications is this person on? Lithium, for example, can elevate your neutrophils. Acetaminophen can elevate or decrease your white blood cell count. So I see that quite often. So make sure you do a thorough evaluation of their medication list. Is this person a smoker? Marique, smoking. I see this all the time. Smoking causes inflammation of their airways, and this will elevate their white count, especially their neutrophils. And I'll tell you what, I actually had a patient whose white count was 22,000, predominantly neutrophils. They started to slow down in the amount of smoking because, of course, I told them, listen, this is not good. They started to cut down, and I noticed that their white blood cell count started to trend downward. And then when they finally stopped smoking, their white count normalized. So I have to stress smoking is huge. I see it all the time. So again, you're trying to figure out what is going on, what could possibly be revving up this bone marrow. And of course, as a last note, things that can cause a bone marrow issue, for example, a myeloproliferative disorder, very seldom will they have only an abnormal white blood cell count issue. A lot of times, the red cells may be affected either with anemia or polycythemia, for example, or their platelet counts may be high or low. Usually, not always, but usually, when there is a bone marrow problem going on, something else is also affected.
We should be diligent enough to review the case. And when should we refer to you, the patient?
Okay, excellent question. Marique, you always refer me specifically, the patient. Always. No, I'm just kidding. Listen.
I know that.
In general, we do not want you to send us a patient for no reason. We want to see patients that need to be seen. So the first thing you have to look at, Marique, is the patient asymptomatic or not? If the person is completely asymptomatic, you can breathe. The next thing you have to look at, do you have a prior CBC to compare to? Because if this is something that's been going on for years, then obviously this is not an emergency. I mean, that's just common sense. The third thing you want to look at is how high of a white count does the patient have? Because in this case, you're telling me it's 14. It's not very significant, okay? So, it all depends. if you notice that the other cell lines are normal, it's only a leukocytosis of say 14,000. A lot of times, Marika, since we know that the majority of times it's reactive and those tend to be transient, then repeat the CBC. Tell the patient to go get another CBC done and see where they fall. Because a lot of times, I see this in my practice all the times. I'd say 60% of the times, a patient repeats a CBC and it may be normal. So again, it was a transient event. Now,
So
if
I
you
looked at
notice
the
the white count
medications.
is very elevated, or if some other cell line is affected, that is when you're starting to think, you know what, this patient may merit a hematology evaluation.
With one observation that I wanted to make, because we have sometimes reactive situations in which the white count goes astronomically high. And you mentioned when you were answering the question C. diff, and C. diff is famous for causing, when it is severe enough, leukemoid reactions, which are
Right.
extremely elevated white counts, and it's due to the sepsis and the infection, not because the patient has a leukemia. So the other thing I wanted to mention was the smoking. Uh, Smoking is famous, and I see in the office this all the time. I cannot tell you that I have not done it in the past. I have sent patients, I have sent smokers to you without noticing. That was a long time ago, though. I learned my lesson, and I asked for. I always go back and look at it. And if the patient is completely asymptomatic with mild leukocytosis and a smoker, I know what's going on. Let's switch gears here and
You know,
go to
Marika, if you don't mind, I'd like to
sure.
tell you one quick thing. Another thing you should always look at when you're looking at a differential, Marika, look for immature cells, promyelocytes, myelocytes, metamyelocytes. You know, unless your bone marrow is extremely active, like for example, overwhelming sepsis, you should not have immature cells in the circulation. So if you do, you look down at the differential, and in the modern machines, the new Coulter counters should tell you, and a lot of times they will tell you not only your differential, but if there are immature white cells, they should tell you. And if you see that, I think in general that patient likely merits a hematology evaluation. The other thing are nucleated red blood cells. You should really never have nucleated red blood cells in the circulation. These are immature red cells. Okay, they're very, very primitive red cells. So if you ever see nucleated red cells, or you see immature cells like myelocytes in the blood, especially, of course, if you see blasts in the blood, send that patient to hematology.
Excellent. Let's switch gears to neutropenia. Define neutropenia, the degrees of severity, and when should we worry about it and send it to you.
All right, so great question. Leukocytosis is one thing. Neutropenia is another. Neutropenia in the right setting could be a medical emergency because remember, that is your neutrophils are the main cells that fight off bacterial infections. So when you see that the person has neutropenia, that's a different ballgame. There, you have to really, you have to be on your A game because you do not want to make a mistake. Now, obviously, depending on what level your neutrophils are, it could be either mild, moderate, or severe. So normal neutrophils are greater than 1,500. So you look at the total white blood cell count, you go down and you look at the neutrophils. If the neutrophils are greater than 1,500, that's normal. Between 1,500 and 1,000, that is mild neutropenia, unless you're African American and you can find a prior CBC, because a lot of times African Americans may have a lower white blood cell count, specifically neutrophils, which is an ethnic neutropenia. Okay, we see that all the time. So just something for you to consider. Once your neutrophils are between 500 to 1,000, that's moderate neutropenia. We're already starting to become concerned. And if it's less than 500, you really have to be concerned. That's a person you have to really worry about because of the fear. Remember, neutropenic fever. And it's not only neutropenic fever, because sometimes these patients, remember, since their neutrophils are low, they may not mount an appropriate immune response and they may not develop fever. I've actually seen patients throughout my career where their white count is very low, specifically a neutropenia. They were not sent to the hospital because the patient didn't have fever. Yeah, they were crashing either way. They were hypotensive, tachycardic. They looked very ill. So don't only rely on fever. So with that being said, you always evaluate the whole CBC. Is the person also having anemia? Does the person have polycythemia? In other words, you want to try to figure out, is there something inherently wrong with the bone marrow? Okay, say an acute leukemia, a myelodysplastic syndrome. What else is going on? Or try through, the history that you're taking. Could this potentially be something transient, like a medication? And we can get into this in detail if you want, but a lot of things can cause neutropenia.
Excellent. Eloy, we send you patients all the time, but you're a busy guy. If you're working in the hospital system, you're employed by the hospital, you're seeing patients all the time. You want your internists that work with you to be your partners in the care of patients, and you want them to do their part, their due diligence, and not just refer patients blindly to you. Same thing happens. I mean, you're a busy guy in your private practice, and you want to take care of the sick people that are under your care. What do you wish we as primary care doctors knew about these specific subjects, let alone, we're not going to talk about the other stuff, but this specific subject of about normal variations in the neutrophil count? What would you love for us to know in order not to send you these cases that we should be able to recognize and manage ourselves?
Excellent. Marrique, the first one would be look at the whole CBC. Notice how I've said that several times, because I see it all the time that they do not, or you're not looking at the whole CBC. Very important. Number two, try to find a prior CBC. When you compare one CBC to another, it's extremely compelling. It gives us a lot of information, because if you look at a prior CBC and you can prove that this is not acute, then you have time to breathe. Now, if you notice that this is something new, then obviously it's more significant. The third thing, as I've alluded to before, when you look at the whole CBC, is it just the white blood cell count that's abnormal? Or do they also have something going on with their red blood cells, with their platelet count? And last but not least, remember I told you, look for those immature white cells and look for the nucleated red blood cells. Extremely important. I'll give you an example. One of the main issues that we worry about is an acute leukemia. You as a primary care, you do not want to miss an acute leukemia. Well, if you have a person with an acute leukemia that's been around for a little while already, you will almost never see a normal platelet count. You will almost never see a normal hemoglobin. You will usually see abnormal white blood cells or immature white cells in the circulation. So again, that just tells you that, you have to look at the entire CBC.
Eloy, I've been doing board questions. I try to do them all the time. I always subscribe to MKSAP. And I've encountered a couple of questions with somebody with benign familial neutropenia, basically referring to the Duffy-Null genotype. And usually the answer to the question is just observe. But they also mention in the stem of the questions always that the Duffy-Null genotype, you can send a test for it, for that genotype. Is that something that you usually do when you see somebody of African descent or somebody from Middle Eastern descent? Hispanics also carry that genotype sometimes. Do you usually, when you suspect that, do you normally send for testing for that genotype or the phenotype for that matter? Or do you just assume that that's probably the case? And if the patient is completely asymptomatic with no symptoms, you just observe?
Rick, I can tell you, not only myself, but a lot of my colleagues. I mean, we always interact. I'm always asking questions to my colleagues, and they're always bouncing cases off of me. The way we all do. No, we usually do not send off for that test for multiple reasons. I mean, one of the main reasons is if I order that test to the lab, chances are they're not even going to know what that lab test is. But in general, Marique, I can tell you that for the majority of the benign neutropenic cases, the familial or ethnic neutropenia cases, I can tell you that at least 98, 99% of the times, you just look at a prior CBC and it'll show you. A lot of times the patient will tell you, they will voluntarily tell you, Doc, I've had this since I was a child. And then the other thing that's kind of a clue, you will notice that they have a neutropenia, that they've had it for a while, and you ask them, do you get sick often? They all tell you the same thing, Maria. They tell you, never. I'm never sick. I never go to the hospital. I never had an overwhelming infection. Or maybe they had one, a pneumonia, the way it can happen to anybody. But for the most part, they do not develop frequent infections. Now, if you do have a person that tells you that they have developed multiple infections, then you have to worry about those other rare entities like the cyclical neutropenia, where they will tell you, there are times that I get sick, but then there are other times that I don't. And then when you look at those CBCs, usually you will see a normal white count, then a low white count, then a normal white count, and then a low white count. So again, that's why it's so important to find a prior CBC, hopefully, preferably multiple CBCs, so you can follow a trend. The trend of the white count is extremely compelling and important.
Great. Thank you very much, Eloy, for being here with me, sharing these minutes with our audience. Where can we see more of you? I mean, this is amazing. It's great to see more of you. How do we do that?
Thank you, my friend. I actually have a YouTube channel. It's called Talking Cancer with Dr. Roman. Marigue, the catalyst for my channel was I got tired of seeing patients come to see me completely unprepared. They would come to see me for, say, breast cancer, and they have no clue, nothing about what breast cancer is. So you know what? I decided to come out with Talking Cancer with Dr. Roman to educate patients. But not only that, I've actually found that many healthcare providers, including primary care physicians, have found value in my videos. So something for you all to consider, Talking Cancer with Dr. Roman, and I hope to see you there.
For sure. I've seen it myself. I'm a follower, and I always look forward to your next video because it's useful not only for patients, primary care physicians, and anybody that can tune to your channel will get something out of it. Thank you for being with me, my friend.
You, my friend.
Take care.
My pleasure.
Okay, let's go to question number 1. A 32-year-old woman of West African descent presents to established primary care. She has no medical history and takes no medications. She reports feeling well with no fevers, recurrent infections, or other symptoms. Her physical examination is unremarkable. No lymphadenopathy or splenomegaly. Laboratory studies show white blood cell count 3,200, ANC 1,300, hemoglobin 13.2, platelet count 245,000. Right there, I see that the only abnormalities are a mildly low WBC, and a mildly low ANC. The hemoglobin is normal, the platelet count is normal. They don't give me a complete differential. So I am framing my mind around these only 2 abnormalities: a neutropenia, a mild neutropenia. A complete blood count performed 6 months ago at an urgent care visit showed similar findings. Duffy antigen testing reveals a Duffy-Null phenotype. That seems to give up the answer to the question. So we're going to continue here. Which of the following is the most appropriate next step in management? Bone marrow biopsy, granulocyte colony stimulating factor therapy, GCSF, reassurance and routine follow-up, referral to hematology, serial complete blood counts every 2 weeks. So, well, A seems very aggressive, all right? This woman is completely asymptomatic, no physical findings, no signs of infections or anything significant. So that's definitely out of the picture. GCSF therapy, this patient is afebrile. She has no problems. The decrease in the ANC is very, very mild with 1,300. So that also seems aggressive. Reassurance, that seems reasonable. we're going to put that one as a possible answer. Referral to hematology. This is almost never the answer in a board question. When you have to refer, they're trying to test your knowledge and your ability to recognize patterns like this. So this is almost never the answer. And if you know and you're familiar with the concept of the Duffy-Null phenotype, you know that this is not the answer. And we're going to get to that really quick. And serial complete blood counts every 2 weeks. Imagine having to have this woman to come to the office every 2 weeks because something that has been with her for her entire life, and now you want to see her every 2 weeks. That seems completely unreasonable. So the correct answer for me here is C, reassurance and routine follow-up. And this patient clearly has a Duffy-Null associated neutrophil count. This is what used to be called uh, ethnic, benign ethnic associated neutropenias. The reason the nomenclature has changed by consensus is because the former term kind of like implied that this was abnormal or pathologic, and it is not. So the preferred term right now it's Duffy-Null associated neutrophil count or DANC, DANC, which basically requires no further evaluation or treatment in an asymptomatic individual. The Duffy-Null phenotype is present. This is much more common than you may think in approximately 66 to 80% of people of African ancestry, and this results in an absolute in a lower ANC, typically between 1,000 and 1,500, without an increased risk of infection. And this is important to realize that these people do not have an increased risk of infection just because the count is slightly low. This is completely a normal variant rather than a pathologic condition. So again, the other choices, guys, with bone marrow biopsy, choice number one, treatment with growth uh, factors, choice number B, hematologic referral, choice C, or frequent monitoring, choice E, are all inappropriate. And this just can perpetuate unnecessary testing and basically wasting your time. The patient is completely stable, chronic mild neutropenia with normal examination findings and absence of infections. This is consistent with a Duffy-Null associated neutrophil count requiring only reassurance and routine primary care follow-up. All right, so now let's go to the next question. And this one, I wanted to really put it very, very. I did this one on purpose, like this, because this is the way when I approach a question that I think of it. I try to summarize every negative finding that they tell me in the STEM, and I'm framing that in my brain that way. So this is a 52-year-old man presenting to the office for a yearly physical exam. He has no complaints. His physical exam is normal. He has hypertension. He takes lisinopril, 10 milligrams. His surgical history, the patient had an appendectomy at 45, not a big deal. 20-pack years of history of smoking. He drinks 6 beers on the weekends, and the vital signs are normal. So 52-year-old man, completely normal, only that he's a smoker and he drinks some beers on the weekends. So seems like a regular guy. His hemoglobin 16.8, well, slightly elevated. There may be something there. Hematocrit 50, slightly elevated. White blood cell count 12,400. Neutrophil count 72% with an ANC of 9,200. The rest of the differential is normal. The platelets are normal. The patient has absolutely no symptoms, no complaints, and the only thing is that he smokes and he drinks some beers on the weekends. So, what is the question? What is the next step in management? He has mild elevated hemoglobin and hematocrit, and also mild neutrophilia. What is the only thing that he does? Well, he smokes uh, and drinks, nothing else. So they are asking you, uh, bone marrow biopsy? Really? Are you going to do that? I don't think so. B, CT scan of the chest with and without contrast? Definitely a distractor. It's here just to try to confuse you because we all know that smokers at this age maybe need a low dose CT scan for screening for lung cancer, but definitely not a CT scan of the chest with and without contrast. Flow cytometry, really out there, not necessary for this mild neutrophilia in this asymptomatic patient, and we know that he smokes. JAK2 mutation testing. So remember, they put that hemoglobin a little bit elevated there just to confuse you and throw this one here. Remember, smoking exposes people to chronic carbon monoxide and also some degree of hypoxemia. He has reasons to have a secondary polycythemia for his hemoglobin to be a little bit elevated. So we don't test for JAK2 mutations in this kind of people with a clear explanation for this mild elevation of hemoglobin. Smoking cessation and repeat CBC in 3 months. This is the only reasonable answer here. And let's see, that is absolutely correct. So this patient with an isolated mild neutrophilia in the setting of heavy cigarette smoking and secondary polycythemia with an elevated hemoglobin and hematocrit. Chronic cigarette smoking is a very well recognized cause of reactive neutrophilia, and this can elevate the white blood cell count by 1,000, 2,000 above baseline. The mechanism involves chronic low-grade inflammation by the smoke, increased circulating catecholamines, and also demargination. We heard Dr. Roman talking about this concept with steroids. So the same thing happens with cigarette smokers. There's demargination of neutrophils from the vascular endothelium. So smokers also commonly exhibit, uh, again, an elevated hemoglobin due to chronic carbon monoxide exposure and tissue hypoxia. So the key features here supporting a benign reactive process in this patient are the absence of symptoms like fever, night sweats, weight loss, fatigue, the normal physical examination without lymphadenopathy or splenomegaly, the normal peripheral blood smear without blast, dysplasia, or left shift. Remember what Dr. Roman was saying, always look at your differential. And a mild degree of neutrophilia, not markedly elevated. The patient is not sick, no reason to panic, and a clear, identifiable cause, which is the smoking. The appropriate management is definitely E, which is appropriate, which is smoking cessation, counseling, and repeat CBC after an interval in order to confirm the resolution or stability. Okay, question number 3. A 58-year-old woman with type 2 diabetes mellitus and recurrent urinary tract infections to establish care. She reports feeling well with no fevers, chills, or recent infections. Her medications include metformin, 1,000 milligrams twice a day, lisinopril, 10 milligrams daily, and 3-methylprim sulfa double strength daily, which was started 6 weeks ago by her previous physician for UTI prophylaxis. Physical examination reveals a well-appearing woman with normal vital signs, no lymphadenopathy, hepatosplenomegaly, or oral ulcerations. So far, we have a 58-year-old woman that is a diabetic with recurrent UTIs and taking 3 medications. Her physical is completely normal. Let's go to the labs. Hemoglobin 13.2, normal. Don't have to remember. MCV 102, a little bit elevated. White blood cell count 2,800, a little bit low. ANC 980, moderately decreased. Moderate neutropenia. Platelet count, normal. Creatinine, 0.9, normal. Folate level, normal. Nevertheless, she has macrocytosis because the MCV is elevated. Vitamin B12, completely normal. So another ruled out cause for macrocytosis. A complete blood count from 8 months ago showed a normal WBC and a normal absolute neutrophil count. So there is something that the question is trying to tell me that happened here after, after this 8 months ago uh, blood drawn that is causing the problem. And the problem is an elevated MCV and a neutropenia that is moderate, something to think about. What is the question? What is the most appropriate next step? ANA. I don't know why. I mean, there's nothing that tells me here that we have to check for an ANA. Discontinue trimethoprim sulfa and repeat CBC in 1 to 2 weeks. Well, that sounds okay. If you know that one of the drugs that can cause neutropenia is sulfonamides, this is something that you really need to consider while you're reading this question. GCSF, why? I mean, the patient is afebrile, no symptoms, definitely not a role here. Bone marrow biopsy, that's way out there. I'm not even going to talk about it. And folinic acid supplementation, I mean, folic acid, the level was normal, as well as the vitamin B12, no role for that. The only possible answer here, it's medication-induced neutropenia, and the main teaching point here is that sulfonamides, either trimethoprim sulfa or drugs used for inflammatory bowel disease like sulfasalazine, can cause neutropenia. That's basically the teaching point here. And we need to realize that. And that's exactly the right answer. All right, guys. So, in conclusion, the CBC is not just a mere collection of numbers, it's more like a snapshot of your immune status, of your inflammatory status, of the functions of your bone marrow. Or it can also be the first sign of an upcoming hematologic malignancy in a very early stage. I want to thank Dr. Roman for his amazing contribution and what he did today. I thank you for watching, and I'll see you next time.